Thanks for tuning in today. I'm Dr. Nick, the Incrementalist. Join me as I seek out the small incremental changes being applied in other industries that we can learn from and that can be applied in healthcare. Can these changes bring immediate value, but also add up to the big improvements and revolution we need in healthcare? Come along with me to explore the possibilities. My innovative guests from around the globe have used small incremental improvements to achieve their moonshot.
And today, I'm delighted to be joined by Dr. Art Papier. He is the co-founder and CEO of Visual DX and a dermatologist. Art, thanks for joining me today.
Hey, Nick, it's a pleasure to be here with you today.
So, as I do always, I think it's important to set the context, understand a little bit about your background. Obviously, your focus on dermatology has played a big part in some of the work that you've done. Tell us a little bit about how you arrived at this point in your career and what that journey consisted of.
Well, my journey started actually way back in medical school when I met Larry Weed, who was the founder of the problem-oriented record in the SOAP note format. And I worked with Larry for 4 years volunteering as a med student on software in the 80s. And I ended up in Rochester, New York, right when this company called Kodak, which many of your young listeners probably never heard of, was announcing scanning film to digital. And they actually had the first digital cameras. And I turned to what became our co-founder of our company, who was chair of the department at the time. I said, this is going to be huge. We're going to get rid of our Kodachrome slides and do this thing with computers and digital images. And this idea was born in the 90s. We started a company just a couple of years after Google was founded. We founded this company before Google Images existed. And the idea really is the visual representation of complexity. And we named it Visual DX, not Derm DX, because we're really focused on all visualization of medical ideas. And we've been off and running for a long time. And, Nick, I have to say, doing the show that's named The Incrementalist is great for me because, the myth is that we're going to have all these kids creating in 2 years a unicorn that, quote, disrupts healthcare. It's a total myth. And so I love talking to a veteran like myself of healthcare IT and talking about incremental change. So this is a lot of fun.
Well, so first of all, I didn't know that about Larry Weed, and I'm so envious because he was such a hero in terms of, how far he pushed. In fact, I've probably watched his video of him doing his talk probably 2 or 3 times, the grainy video, the move. And in fact, his son, I met his son a while back who's produced a book. So I just can't believe that. And
we'll schedule a separate interview on that because I think value Larry.
Such a leading light in our space. Yeah. And then, the incremental piece from my perspective, obviously, it takes 10 years to be an overnight success. And that through that sort of journey. So obviously an exciting time. I think, the move from physical film to digital film, you obviously saw it. You should have talked to a few folks at Kodak, I think, because they developed it, yet they seem to miss it.
Well, we had conversations with them, and I liken it to the movie Groundhog's Day, where the same conversation would repeat itself all over. And that's another story in itself. Well, let's not digress. Let's get into
Oh, my goodness. There's so many spawned sub-shows as a result of this. So, Visual DX. So you focused on imagery at a point that we were moving to this digital imagery. And obviously, you must have seen a huge change and improvement in terms of what we're capable of. Tell us a little bit about the formation of that company and what you were thinking at the time when you put it together.
Well, I worked in a rural area as a dermatologist, and one of the things I was struck by was that non-dermatologists, such as primary care physicians and ER physicians, see a lot of skin presentations. In fact, the data shows that 65% of skin presentations in the U.S. are not seen by dermatologists. In the U.K., it's probably 95% of skin presentations are seen by GPs, not dermatologists. And what I saw was a lot of error around common diseases. The expectation is not that your GP is going to diagnose you with some rare genetic disease presenting on the skin. But what I saw was dermatologic presentations of things like herpes being missed. And the reason is variation. So variation of the common causes a lot more error than missing rare diseases, because common diseases happen commonly. So I became very, very interested in this area of diagnostic improvement through visualization and focused on this idea of variation. And we created and got a software patent on a specific way to develop a differential diagnosis and display variation digitally.
As you think about that variation, and I got to be honest, I remember vividly my dermatology experience and thinking, how on earth could I absorb all of this information to be sufficiently agile to know the difference between significant and non-significant? I mean, that, as a filter point, if you're non-specialist and you're the primary point of contact, that's really the major purpose is what needs to happen and can you get it to the right person and not waste the resources that are limited. How do you go about sort of addressing that with technology? I mean, this is not an easy problem to solve.
Well, we're not a believer in man versus machine, that we're just going to get it all done by the computer and replace humans. So we're talking about augmenting the brain. And the question is, can we transition medicine to become highly reliable? So we move away from memorization and we're augmenting the brain in the exam room. And so it turns out that images and visualization can transmit information much quicker than just putting a textbook online. So if you're going to give information to a clinician in a fast-paced environment, you have to do it in under a minute. So, imagine that you're an ER physician, a patient comes in and the board in the ER says fever and a rash. And you're an ER physician, there are diseases that can kill the patient that present with fever and a rash, right? Forms of sepsis. So how do you augment that physician so they are considering things that in a rush, they might not consider, right? And so what you do is you put together a very intelligent search with a visual display that handles the variation and allows for comparison so that we can take advantage of that part of the human brain that involves visualization. And a lot of these ideas are derivative, so I paid homage to Larry Weed because a lot of these ideas are derivative from Larry, but the other is, Daniel Kahneman, who wrote the book Thinking Fast and Slow, talks about how humans do thinking two different ways. One is pattern recognition, and then the other is analytical thinking using our cortex, right? And it turns out we prefer pattern recognition. But pattern recognition is fraught with bias and errors like premature closure, anchoring, and all these forms of bias. So when building a system like this, you have to consider that the human brain processes in two different ways, pattern recognition and analytic thinking. So in the development of our technology, we've been thinking about how do we balance the different types of thinking that clinicians do.
So as you think about that bias and the challenge, that obviously led to sort of, I don't know if it was a realization or how you came to it, but there's lack of representation in the core information that we absorb as physicians when we go through the learning process. And you were seeing that almost in more data that you are gathering to try and develop these systems. Tell us a little bit about your sort of thoughts around that.
Well, I think what you and I went to medical school where we trained on kind of prototypical and classic examples of disease, and we'd read the books and memorize the classic. And then I became a dermatologist, and I realized that diseases don't always present as the classic, and it's probably true for the internal medicine diseases. But in dermatology, it's just blazingly obvious that common diseases, you take herpetic infections, don't always appear on the lips or genitals. Like common, herpes simplex. I saw a patient, a pregnant woman, I was called to the hospital. She just delivered. They didn't know what this rash was. It developed right before delivery. And she had herpes on her thigh. And, the doctors in the hospital would know herpes on the lips or the genitals. So I realized early on that there's a lot of variation, and the brain can't handle all that variation. And our paradigm for educating doctors is to memorize the classic. And then we expect them to generalize in the real world. And so databases can catalog variation, and you can develop a profile of the spectrum of disease. And so we've been relentlessly cataloging cases for 20 years. And the cases have tags on them. The images have tags. And so when machine learning came along, we realized that, as you know, good machine learning requires good data. And the metadata that goes on the imagery is key. So we started training about 4 or 5 years ago on the image data that we have, and we discovered that we can do a really good job on machine learning of skin images. But the other thing that we discovered, that the machine learning also has difficulty with images of diseases that look very, very similar. So an example would be a viral exanthem, the rash of mononucleosis, the rash of a viral illness, as opposed to the rash of a drug reaction, right? Those rashes, we call them morbilliform rashes. They look very similar. If after practicing dermatology 27 years, you put in a room a patient with a viral eruption and a patient with a drug eruption, you gave me no history, I wouldn't be able to tell you what the patient had. And the machine learning likely will not be able to tell you what the patient has. So you need history. And that's key to what we do, is the interplay of other factors with the imagery. So yes, machine learning is incredible. We're going to make fantastic progress in machine learning of skin lesions and being able to tell the difference between melanoma and a normal mole. But some of these rashes you need to know. Did the patient travel? Did they go to Peru? Did they go to Haiti? Did the patient start a new med? And bring that data in from the EHR. So it's that interplay of words and imagery that is our sweet spot, what we're really focused on.
So as you look back at the development of the solutions and gathering this data set, which, has been a huge task, something that didn't exist. I mean, at the time that you started out, we were just moving to digital. So you were right at the outset. Anything that you look back and you go, gosh, I wish I'd known that at the time when we started this process, were the sort of insights that you came to subsequently that you go, wow, if we'd known that back then, we would have done things slightly differently?
Well, actually, what I've learned along the way doesn't have to do with technology. The technology is easy. What's difficult is the culture of medicine. And, I'll be honest, I was naive about the culture of medicine. I think that we as physicians, we really want to do right by our patients. But the pressure of the medical industrial complex that we're part of doesn't put the patient priority first. So a lot of decisions get made in healthcare systems around money and not around doing right by patients. And, I think if I knew more about how broken our medical delivery system is and how our educational system, what a problem that is. Because, and Larry Weed told me this, in the 80s, he'd say to me, Art, why are the politics so brutal in academia? I go, why, Larry? He goes, well, Art, the stakes are so small. And so, he was full of this wisdom 50 years ago, trying to key me in as a naive medical student that we're going to fix medicine. And, before he died, someone said to him, Larry, the problem with you is you're way ahead of your time. And he said something like, well, I'm 86. What do you want me to do? Live to 115? Yeah. So anyhow, I think we were naive about the culture of medicine and the fact that, we really need to help physicians. And we are at our company, we get feedback from our users, from our doctors and our med students and residents. They say things like, I love Visual DX. It helped me solve a case, right? But that's not the priority of healthcare, unfortunately.
So for those of you just joining, I'm Dr. Nick, the Incrementalist, and today I'm talking to Dr. Art Papier. He is the co-founder and CEO of Visual DX and a dermatologist. We were just talking about the educational system and some of the learning insights and the challenges of dealing with a system that culturally doesn't focus on the patient, is focused more on the business of medicine. Certainly one of my realizations that I think was a surprise to me as I've sort of discovered that. Fast forward, we're now in, month X of pandemic, depending on when you hit the start time. And obviously, one of the things that's really emerged and is clear is that this is not just a respiratory illness. It has other sequelae that we see as a result. And I know you've had some involvement as a result of that. Tell us a little bit about your experience around COVID-19 signs and symptoms that you've started to see and you've been helping with.
Well, we track infectious disease, and it's a really important component of Visual DX. So pretty much every infectious disease on the planet is in our system. And, you could always search by any country in the world to see if you had a traveler or an immigrant or Visual DX was being used overseas, you'd be able to see the infectious diseases that are endemic in that country. So when the novel coronavirus came out, say in December, January, we added it into our system in late January. And during the period, we started reaching out to our contributors to get first pulmonary examples of the chest imaging complications of COVID. And then eventually there was a study in Spain that showed that there were skin findings. And we started aggregating images of the skin findings, which we've been doing. But I think the more interesting part of the story is really the diagnostic harm that's happening because of COVID. There are now countless cases of people that had diagnostic delay where there was premature closure on the diagnosis being COVID when it wasn't. So it really is, it's classic epidemiology and what's your pretest likelihood for your clinical decision-making? Where are you in America today? And so, in New York City in April or May, if you had fever and a cough, high likelihood you had COVID. But today in Manhattan, maybe not in Brooklyn where it's starting to surge, it's still very low likelihood if you have a cough or fever that you have COVID. And here in Rochester, New York, we have thankfully have a pretty low base rate right now. So, I heard a story from a pediatric colleague of mine. A teenager comes into his office a month ago and has shortness of breath and fever. And the entire clinic's going down the street of COVID. And being a super sharp pediatrician, he gets the parents out of the room because he had a hint of what was going on. Parents leave the room, says to the teenager, "Have you been vaping?" And it turns out this kid was vaping. And he didn't have COVID. He had EVALI, that vaping-induced lung disorder that was the public health crisis of a year ago. That's right. What we're talking about. So you could easily see how premature closure comes to the fore in an age where we're dreaming about COVID. I mean, the COVID is in every thought we have, right? So there is a tremendous need to augment the brain to consider other possibilities and have systems that are smart enough to take on, the timing and the location of where you're practicing.
So one of the challenges around this that, has been amplified amongst many others with this pandemic is the racial disparities. And that's, in evidence within all areas, but I think almost more so with Visual DX, because you're seeing that without representation or even examples to be able to point to. Tell us a little bit about your experience and, some of the things that you've done as a company to try and address that.
Well, we've been purposeful for 20 years in being equitable in the imagery we collect. And I wrote a paper in 2006 called Disparities in Dermatologic Resources, where we looked at the textbooks, because that was more important than the internet at that time, to see if there really were enough imagery of diseases in people of color. And we showed in that paper there weren't. But the company has always been focused on this and being equitable, reducing bias. So we've arguably maybe have the best imagery of disease presentations in people of color in the world. And along came the George Floyd tragedy, and we started getting a lot of interest. We've had, despite how financially tough the times are for many hospitals, we've been licensing Visual DX frequently since June. And it's because, the CEOs of hospitals are having, moments of solidarity for the staff, white coat. We get out in front of our hospital, we took a knee in support of Black Lives Matter, which is great. But what are we doing for hiring, for accepting people of color into the residencies? And from our perspective, what are we doing with our knowledge resources? Because there's systemic bias in the knowledge resources. So thankfully, some of these systems that don't have access to Visual DX are reaching out. And this is the fact that, I said to many chief medical officers and chief medical information officers years ago, I would show them the skin of color content, and I'd say, for this reason alone, you should license Visual DX. And, some systems, we're in over half the med schools. We have 2,300 hospitals and clinics licensed, and some licensed for that reason. But others, it fell on deaf ears. And now I think one of the positive things is medicine is saying we do have a problem in medicine. We have to do more than just words of solidarity.
So not a lot of time left. Tell us a little bit about some of the things that you've done to date and where you see this going. I think you've amassed possibly one of the best diverse collections of imagery. So that starts to help solve the sort of input problem from machine learning context. Also from an educational standpoint, I think you've added to your resources at the organization. Tell us in the time remaining, what are you excited about? Where do you see this going? And how do we fix this? I mean, it's been so pervasive for so long, but we have a moment. There's a crisis, and, don't let a crisis go to waste is, famously the phrase.
So we had a filter in Visual DX where you could filter by skin type. And what we discovered is most of our users did not know that the filter was there. And so from a technology point of view, we jumped on fixing this. And so in 1 week, we have a new release where we're bringing to the homepage where it has dermatology all colors, and it says dermatology skin of color. And it's just going to be right there up front so our users know that this tool is there. And that was something that we were blind to. We didn't realize our users didn't know the content was in there. And so we bring it to the homepage. The other thing is we're partnering with a major partner that I can't announce today to do a series of webinars on bias in medicine, which is going to be a 4-part series in partnership with some leading players in this. And we're going to be announcing this maybe the end of this week or next week. I think it's going to have a huge impact to educate doctors on why this is a problem and why we need to get serious about this problem. And so we're just really leaned into this, and to make sure people know this is a problem that we need to work on and be serious about through medical education and through information technology. And your audience of health IT experts should know that there are technology solutions to bring this knowledge right into the exam room. And the information also, really importantly, impacts patient education. So Visual DX is used in the exam room to reassure anxious patients. And in this time of COVID, where everybody thinks they have COVID when they don't, right? We need resources to educate patients, and pictures are one of the most powerful way to educate patients.
I think the most telling thing that I got from that was the fact that here you are 20 years in with, a solid focus on trying to address that bias. And yet ultimately you discovered that there was not a deliberate bias, but the inability to represent that available tool set, which you fixed in, short order. It's so hard. You've got to keep focusing and returning to that challenge, to challenge yourself over these biases that I think we're inevitable, we're born with. I mean, you have to fight it, and that fight never stops. Just delightful to sort of hear about that and hear the progress. Excited to hear about the announcement. Just remains for me to thank you for joining me on the show. Always a pleasure to catch up.
Hey, Nick, it's just fantastic to catch up. And I love the fact that I'm on the Incrementalist talking to you about a 20-year journey to fix broken healthcare. Thanks a lot.
Thanks for joining me today. Do you have any better ideas, or have you found a small incremental change that's brought about a big improvement in your world? Let's continue the conversation on our hashtag, the Incrementalist, or share with me at Dr. Nick1 on Twitter. You can find more information about the show on our program page at healthcarenowradio.com. And tune in next time to hear my discussions with leaders and innovators from around the globe who've revolutionized their space by using small incremental improvements to achieve their moonshot. I'm Dr. Nick, the Incrementalist, and I'm starting a revolution through evolution.